In the next slides, we are going to go on other common hemolytic anemias in pediatrics, especially hereditary spherocytosis as an example of membrane defect, G6PD deficiency as an example of the common enzymatic defect in red cells causing hemolysis, and autoimmune hemolytic anemia as the common immune hemolytic anemia in pediatrics. Hereditary spherocytosis results from molecular lesions of the red cell membrane at the cell membrane skeleton level, affecting the red cell membrane proteins, spectrin, ankyrin, protein 4.1, and BEN3, and the end result is rigidity of the red cells. When the red cells are rigid, they are spherocytes, they are no longer biconcave, they are easily sequestered in the splenic capillaries. It is inherited as autosomal dominant in 75% of the cases. So a positive family history is usually present. There are 4 phenotypes according to the severity of hemolysis mainly. The most common is the moderate form. It's 60 to 70%. Typically, they have anemia, hemolytic anemia. They have jaundice, indirect hyperbilirubinemia, and they do have splenomegaly. And many have gallstones, and this is very characteristic. And symptoms and signs usually appear in childhood. A mild form occurs in 20 to 30%, very mild anemia, and maybe even asymptomatic. 10% may have a moderate to severe form requiring frequent transfusion due to severe anemia. The very severe form in 3 to 5% have life-threatening anemia requiring frequent transfusion, and they do not respond except to, usually they need splenectomy at some time of their life. It's an autosomal dominant disorder, as we said, anemia, jaundice, and splenomegaly. Diagnosis: peripheral blood contains spherocytes. Spherocytes, they are small in size with low MCV, and there is no central pallor. Under increased osmotic fragility. Osmotic fragility test is a test used to measure erythrocyte resistance to hemolysis while exposed to varying levels of dilution of a saline solution. When erythrocytes are exposed to a hypotonic environment, water enters the cell and causes swelling and lysis. In hereditary spherocytosis, this is normal, and this is hereditary spherocytosis. Hereditary spherocytosis, the cells cannot tolerate hypotonic solutions, so they are going to get lysis at a higher concentration than the normal red cells. So there is an increased osmotic fragility. The other disease causing hemolysis, as an example of enzymatic defects, is glucose 6-phosphate dehydrogenase deficiency. The glucose 6-phosphate dehydrogenase is an enzyme. Its role is a prevention of damage to the red cells when they are exposed to oxidizing material. This disease is an X-linked recessive disorder, means affects males and the females are carriers. However, some of the heterozygous females may express the disease variably, and this is due to variable theories. One of them is called the Lion hypothesis. There are 3 types of G6PD deficiency. There is the A- phenotype in the blacks, there is the Mediterranean phenotype, which is severe phenotype, and there is the Canton phenotype in Southeast Asia, which is one form of chronic hemolytic anemia. But the A- and the Mediterranean types, they cause acute hemolysis induced by drugs, ingestion of fava beans, or by infection. And during the attacks of acute hemolysis, they are characterized by the presence of fragmented red cells in the peripheral blood, by the presence of spherocytes, increased reticulocytic count, and what we call Heinz bodies in the red cells. The attacks characteristically in G6PD deficiency are self-limited, and the patient have a normal blood picture between attacks. How to diagnose? We are going to diagnose by the assessment of G6PD enzyme assay, revealing low enzyme levels in the red cells. As I said, hemolytic attacks are usually self-limited. Severe cases may need transfusion of red cells. The main problem, it is an intravascular hemolysis, and if not properly managed, you get the risk of renal tubular injury. This is a list of the drugs causing hemolysis in G6PD. They include mainly acetylsalicylic acid, ascorbic acid as a drug, chloramphenicol, sulfonamides, nitrofurantoin, quinolones, exposure to naphthalene. We should be careful to these kids when we do give them herbal drugs. It's very important to be careful because some of them may cause hemolysis, and also exposure, as I said, exposure to naphthalene and insecticides can cause hemolysis to these kids. The other disease causing hemolysis, and it's acquired hemolysis, is autoimmune hemolytic anemia. Autoimmune hemolytic anemia, it results from autoantibodies that bind to the red cell surface membrane, and they lead to premature red cell destruction because they are recognized when they pass into the reticular endothelial system. So hemolysis is an extravascular hemolysis. They can be classified as either warm antibodies. These autoantibodies are warm antibodies. They are mainly from the IgG subclass, or they are cold antibodies, what we call cold agglutinins. There are IgM subclass, and the cold agglutinin disease is more common in older age group. Or autoimmune hemolytic anemia can be classified according to the cause into primary idiopathic or secondary, and the secondary can complicate malignancies, can complicate traumatic autoimmune disorders, can complicate infections like mycoplasma and viral infections, and can occur as a drug side effect. As I said, hemolysis is extravascular. Usually there is pallor, jaundice, splenomegaly, and features of the primary disease. Anemia in warm autoimmune hemolytic anemia is usually associated with increased mean corpuscular volume due to increased reticulocytic count, indirect hyperbilirubinemia, and there is a specific test called Cohn's test. Cohn's test, a direct and indirect Cohn's test. Direct Cohn's test detects antibodies coating the red cells. There is another Cohn's test which we call the indirect Cohn's test. Indirect Cohn's test is going to detect circulating antibodies. But in patients with autoimmune hemolytic anemia, usually the antibodies are coating the red cells. So we have a positive direct Cohn's test. Warm autoimmune hemolytic anemia, which is more common in children, is treated with corticosteroids. If refractory, we use intravenous immunoglobulins as immunomodulators and immunosuppressive therapy. Severe cases may request splenectomy. In the next module, we are going to discuss aplastic, hypoplastic anemias. I'm waiting for your questions. Thank you.